You've had your scan, you waited anxiously for the results, and then the report comes back. Everything looks normal, but you're still in pain, maybe even worse than before. So what now? This is one of the most common situations I see in my clinic. Patients are told their MRI or ultrasound is normal, so they couldn't possibly have endometriosis. And yet, when we operate, we often find significant disease that was never picked up on imaging in the first place. Hi, I'm Dr. Abhishek Mangeshikar, robotic excision surgeon and endometriosis specialist. In this video, I'll explain why imaging often misses endometriosis, the limitations of MRI and ultrasound, what proper protocols look like, and how to make sure you get the right diagnosis. Now, let's be clear. Both MRI and ultrasound are powerful tools, but for endometriosis, they have very real blind spots. Here's what they can see well. Deep infiltrating disease like bowel or bladder nodules, ovarian endometriomas, which are the classic chocolate cysts. Here's what they often miss. Superficial peritoneal lesions, which are the commonest type, flat plaques, clear or white lesions, or even early nerve involvement. Small nodules in unusual sites like the parametrium, ureter, or diaphragm. It is heavily operator dependent. Imaging is only as good as the person doing and interpreting it. Most routine ultrasounds and MRIs are focused on the uterus and ovaries. If those look fine, the report often says normal. I've personally seen MRIs where a bowel nodule was present, but the radiologist either didn't look for it or mistook it for stools. Without specific training in endometriosis imaging, these subtleties are very easy to miss. Here's the danger. A normal MRI or ultrasound doesn't mean that you don't have endometriosis. I've seen women delayed for years and years, reassured after normal scans, only to come to surgery and be found with severe advanced disease. And these are not from some small centers in the villages of India. They have come from Ivy League universities in the United States and the Western world as well. To maximize detection, the scan has to follow a specific protocol. The MRI protocol for endometriosis is high-resolution T2 weighted images in multiple planes, which have thin slices for greater detail, coverage from the diaphragm to the pelvic floor, not just the uterus and the ovaries, targeted evaluation of the bowel, bladder, ureters, parametrium, and rectovaginal septum. Rectal or vaginal contrast in some cases to help us better map bowel or parametrial disease. The ultrasound for endometriosis should be done by a specialist in endometriosis ultrasound or by the surgeon themselves if they've had the appropriate training for. Dynamic real-time evaluation, which means watching how the organs slide or stick to each other. We need to focus on the posterior compartment, which is bowel, bladder, and side walls. There should be an ability to recognize deep nodules, adhesions, and check for ovarian mobility. The report should be written in clinical language. For example, a rectovaginal nodule 2 centimeters tethering the rectum rather than just uterus and ovaries normal. This level of detail is not the default in most centers. It must be specifically requested, and more importantly, it must be done by someone with proven expertise in endometriosis imaging. Who reads the scan matters the most. At the end of the day, imaging is only as good as the eyes that read it. That's why, in my own practice, I do my own ultrasounds and I read my own MRIs. Not because I don't trust radiologists, but because the surgeon who is going to perform the surgery must be intimately familiar with the imaging. When I look at a scan, I'm not just looking for a cyst or a mass, I'm mapping the disease in my head, planning where I'll need to dissect, which organs may be involved, and whether I need to involve other specialists like urologists or colorectal surgeons. That kind of correlation between imaging and surgery is critical, and it's one of the biggest reasons why patients get missed in general practice. Even with the best MRI and the best ultrasound, some disease will still be missed. Superficial peritoneal lesions, microscopic implants, early nerve involvement. These can only be identified during surgery, and even then, only by a surgeon trained to recognize the many different appearances of endometriosis. That's why surgical visualization, ideally with excision, is still considered the gold standard for diagnosis. One patient I treated had 3 MRIs over 5 years, all reported as normal. Her symptoms were severe: pain with bowel movements, cyclical pelvic pain, urinary urgency. When we finally operated, we found deep rectovaginal disease, bilateral urethral involvement, and nodule on the diaphragm. Most of this disease was still visible on her previous MRIs, it was just not reported. And when we went into surgery and removed all of this and got a histopathological confirmation of the diagnosis, none of her previous reports had picked up on these imaging findings. But when we reviewed the imaging previously and the one we repeated at our center, it showed the disease was still present even 5 years ago. If we had relied on their imaging alone, she would still be suffering today. Here are some questions to ask before your scan. If you're getting imaging for suspected endometriosis, always ask, will this be an endometriosis protocol MRI or ultrasound? If you have upper abdomen or chest symptoms, will it cover from the diaphragm to the pelvic floor? Who will be reading the MRI, who will be doing the ultrasound, and how many endometriosis cases do they see per year? Will they specifically report and comment on bowel, bladder, ureters, and parametrium? Will they give you an NGN score classification and the data that's needed to make sure this language is universal? These questions ensure you're not just getting a generic pelvic scan that misses the point. This is your step-by-step path to the right diagnosis. Document your symptoms in detail. Timing, triggers, severity, bowel or bladder impact. Get expert imaging, MRI with an endometriosis protocol or ultrasound or both. Correlate the imaging with a specialist's clinical exam. Scans are just one piece of the puzzle. Consider surgical evaluation if symptoms are severe and suspicions remain high despite normal imaging. Endometriosis is a complex multi-organ disease. A single normal MRI or ultrasound should never be the end of the story. The right diagnosis depends on the right imaging protocol, the right person performing and interpreting it, and sometimes the right surgeon's eyes during surgery. If you've been told your MRI or ultrasound is normal, but you're still in pain, don't give up. Share this video so others know that they're not alone and so they can push for the right evaluation. And don't forget to like, share, and subscribe so more women can access evidence-based information and avoid years of unnecessary suffering.